Hello, my name is Gerald Lerman, and I'm Clinical Professor of Anesthesiology at the John R. Oshai Children's Hospital and Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York. And in this session, we'll be discussing pediatric anesthesia equipment in the airway and fetal circulation. We begin by outlining how to choose the correct diameter of an uncuffed endotracheal tube in a pediatric patient. Looking first at premature infants, the size of the endotracheal tube is related directly to the weight of the infant. And that is, for infants under 1,500 grams, we will routinely use a 2.5 size internal diameter tube. For a child 1,500 to 2,500 grams, we'll use a 3.0 millimeter internal diameter tube. And for those greater than 2,500 grams in full-term neonates, a 3.5 millimeter ID tube. For infants, we move up to a 4.0 millimeter tube at about 1 year of age. And for those older than 1 year, the formula generally follows age over 4 plus 4, where the age is in years. Some use age over 4 plus 4.5, particularly in children who may be larger than the expected size for their age. But there are those who have recommended to use the diameter of the 5th digit as a predictor of tracheal tube diameter in young children, and that really holds no merit whatsoever. The depth to which we place an endotracheal tube from the alveolar ridge follows a very simple formula in premature babies, 123-789, where the first three numbers are the weight in kilograms, 1, 2, or 3 kilograms, and the second three numbers denote the depth to which the tube should be placed. That is 7, 8, or 9 centimeters for the corresponding weight. For full-term neonates, we use 10 centimeter markings at the alveolar ridge for most babies. And then thereafter, the depth is 10 plus the age in years. Excuse me. So in a 2-year-old, the tube should be taped about 12 centimeters at the alveolar ridge. Of course, we're going to verify that by auscultating the left lung in particular to be sure that there is adequate air entry and that the tube is not preferentially endobronchial on the right side. And that is where the tube may go if the tube is placed endobronchially, down the right side before the left side. Excuse me. Of late, there has been great interest in replacing uncuffed tubes with cuffed tubes. And there are several reasons that have been put forth to justify this change in practice. Reduced number of reintubations, because there's either too large a leak or the tube won't pass the cricoid ring. A reduced air leak to reduce OR pollution. To get more accurate measurements of end-tidal measurements. To more accurately measure lung compliance with a lot of programmed anesthetic machines, monitors, and for the reduced risk of aspiration and airway fires. The latter 2 points certainly have not been evidence-based recommendations. There is no greater risk of a fire or aspiration with an uncuffed tube, something we have done for more than half a century. Nonetheless, people are moving towards uncuffed tubes. And one of those that has caught the eye of many practitioners has been the Microcuff tracheal tube. In fact, large studies have demonstrated that it's particularly safe in older children, with more than 3,000 children being studied, showing no risk of subglottic stenosis or edema. However, fewer than 5% of those patients studied were neonates. I would also point out that some of these tubes are far more expensive than the standard uncuffed tracheal tube, and one may wish to adhere to cost containment and limit the number of the expensive tubes in your practice. The microcuff tube is designed by pediatric anesthesiologists and does offer a number of features that are particularly appealing. And that is, the cuff is elliptical rather than spherical. So the pressure is uniformly applied over a larger surface area in the trachea. The sealing pressure to prevent a leak is much lower than in the standard cuffed endotracheal tubes, only 10 centimeters of water. A very important characteristic, because that buys us a lot of margin should the cuff swell because nitrous oxides are administered, or the temperature of the body warms the gas in the cuff, and the pressure may increase. But it really has a long way to go before it impairs the circulation. But there is no Murphy eye on these endotracheal tubes, and therefore if the tube is close to the carina or endobronchial, the possibility of ventilating the other lung is much less. And the reason there's no Murphy eye is because this elliptical cuff is much closer to the tip of the endotracheal tube. The doctors who developed these tubes have also recommended that we use the depth markings indicated on the distal end of the tube rather than the formula for placing the tube, in particular because of these two reasons that I just mentioned. That is, that there is no Murphy eye and that the cuff is very close to the tip, and so we don't want to accidentally end up with an endobronchial intubation. But above all, they have been strong advocates for monitoring the cuff pressure for all cuffed endotracheal tubes in order to ensure that we don't sustain any subglottic edema. So on this slide, we see on the left side four commonly used cuffed endotracheal tubes in children, with the microcuff on the far left, and you can see the elliptical cuff, elliptically shaped cuff, whereas these other ones are more spherical. And on the right, we can see the mean pressure that is required in the cuff to seal the airway, with the microcuff having by far and away the lowest mean pressure, 11, or we said earlier 10 centimeters of water, compared to the other shaped cuffed endotracheal tubes for children, somewhat 10, 20 or so centimeters of water, greater pressure to seal the cuff. In terms of monitoring the cuff pressure throughout the anesthetic, perhaps every 30 minutes or 40 minutes, you could purchase a commercially available monitor, or others have advocated hooking up a pressure transducer and measuring the pressures within the cuff on a invasive pressure monitoring screen. And you can see here on the right the cuff pressure in endotracheal tube that has been inserted in the patient over a period of time with pretty stable pressures and not particularly excessive pressures at any time. Although in some cases the pressures exceeded 25 centimeters of water, which are probably less desirable. And if the cuff pressure were checked, we would deflate the cuff somewhat in order to bring the pressure down. Now, in terms of the depth to which we insert these microcuff tubes, and I mentioned we should use the markings on the tube, you can see here the distance to the carina from properly placed tubes in kids from 0 to 16 years of age. And the light line underneath these show where these depth markings end up where the head flexed maximally onto the chest. And so we do get somewhat close to the carina when with head flexion after these properly placed tubes, but none of the tubes are actually beyond the carina and endobronchial. So these markings appear to have be very robust and useful in infants and children of all ages, and should be adhered to if inserting a microcuff tube. But we do want to issue a small amount of caution in neonates and infants, and particularly the limited data that shows the safety of these tubes in young kids, and that the tracheal tube size recommendations on the packaging for these tubes suggest that a 3.0 millimeter ID tube is only effective for more than 3 kilogram full-term neonates, and a 3.5 is for a greater than 8-month-old infant. These contrast with the 3.0 and the 3.5 millimeter sizing for kids above 1,500 grams with an uncuffed tube, and a 3.5 millimeter size ID uncuffed tube for a full-term neonate. So it is important to use the tube based on the manufacturer's recommendations, because we reported a number of cases of post-extubation stridor previously, and then reviewed a large number of our NICU infants who were treated with a microcuff tube versus an uncuffed tube, and found about a 3-fold greater incidence of transient stridor when the microcuff tube was used in these ex-premature infants. And so this notion that we should be cautious in using these microcuff tube in very young kids, and that the sizes are not designed for such small airways, needs to all be considered if one moves to using these tubes in ex-premature and very small infants. Now, a word about preformed tubes, because we all use preformed tubes, and in this case we're talking about nasal tubes with cuffed versus uncuffed distances beyond the bend of the tube, and we can see some interesting disparities. And that is, with these Parker and Rush tubes, there may be as much as 9 centimeters of longer tube with a cuffed bent tube, even though the tubes are the same diameter compared to the uncuffed tubes. And the problem is failure to recognize this and insert the elbow just far enough or close to the nose to ensure the tube is allowing bilateral ventilation may not be considered. And people push the elbow all the way down to where the elbow is in the nostril. With these cuffed tubes, for example, a 5-cuff tube, there's as much as a 4 centimeter difference, which compared to the uncuffed tube, which would render the tube endobronchial. So we have to ensure that the uncuffed tube is placed with the elbow at the nostril, but when it comes to a cuffed version of the same tube, we may have quite a large amount of the tube sticking out of the nostril in order to ensure bilateral lung ventilation. In the next segment, we're going to talk about transition to fetal circulation. The lungs don't really play any role in gas exchange in the fetus. All of the gas exchange that occurs through the placenta, and it is vital that the placenta is functional and not abrupted from the wall of the uterus in order to ensure adequate oxygen delivery and CO2 removal from the fetus throughout the 40 weeks of gestation. Having said that, the lungs do play a role, and they have a very important role, maybe not in gas exchange, but certainly in development, because the pulmonary epithelium actively secretes fluid that fills the lungs during gestation, and as well the child swallows the amniotic fluid, and this helps to develop the lungs normally. Excess fluid passes into the trachea and the oropharynx, and it distends the lungs and allows for critical development at various stages. The fetal nutrition and oxygenation, again, depend on this uteroplacental blood flow and the patent vessels in the placenta. 12% of the cardiac output in the term fetus reaches that placenta, whereas in the non-pregnant uterus, there's only 200 cc's a minute, 1/3 the amount of blood flow. So it really reinforces the importance of that uterine blood flow to ensure that adequate gas exchange occurs to the fetus in utero. And that gas exchange, the oxygen, moves by passive diffusion from the uterus to the umbilical circulation. However inefficient it may be compared to the lungs, it is the sole organ. And note that on room air with a maternal PO2 of 100 millimeters of mercury, the umbilical vein or the fetal left ventricle only sees 30 to 35 millimeters of mercury. And even administering 100% oxygen to the mother, we're hardly able to increase the PO2 in the umbilical vein or left ventricle. Now this slide shows some of the transition saturations in circled numbers and blood pressures in the ratios from the inferior vena cava through the left ventricle and right ventricle and down the aorta. We can see on the far right the rather pathetic looking lungs, which don't really have much of a role, receiving less than 10% of the cardiac output in utero. But there's some notable features here that we will emphasize on the next few slides. And first is that 60% or more of the oxygenated blood from the placenta comes back through the ductus venosus and into the left atrium and ventricle to emerge into the aorta and perfuse the coronary arteries and the brain. And these are directionally diverted blood to ensure that the most oxygenated blood gets to the most important areas of the heart and brain. The remainder of the blood goes through the right ventricle, containing less oxygen than on the left side, and they end up through the ductus arteriosus, perfusing the lower extremities and the rest of the organs. To help oxygen be delivered to the fetal tissues, important to understand there's a large difference between the hemoglobin F in the fetus and hemoglobin A, that in the adults. The most notable difference that we are often asked about is the difference in the P50, being 27 in hemoglobin A and only 17 or 19 with hemoglobin F. This left shift of the oxyhemoglobin dissociation curve in the fetus ensures delivery of oxygen even at low tensions, oxygen tensions. Now we can see a little closer pictorial representation of how the blood is diverted and circulated in the fetal circulation, because it really depends on 3 shunts, 2 of which are shown here. And that is, again, the blood is shunted from the inferior vena cava coming from the placenta, primarily into the left ventricle, directed through the foramen ovale, and then up to the aorta to perfuse the brain and the coronary arteries. Whereas the less oxygenated blood from the superior vena cava and some from the inferior vena cava traverse the right ventricle and get out the pulmonary artery through the ductus arteriosus and down to the lower extremities. Ductus arteriosus, foramen ovale. And the third shunt is the shunt that directs the blood from the umbilical vein away from the liver and directly into the heart. And it is streamed, as I said, into the left ventricle to perfuse the brain with the most oxygenated blood. Ductus venosus, bypasses the liver, allowing oxygenated blood from the placenta to reach the brain. And when we put the whole picture together, we can see in this slide that we have our placenta with our umbilical veins bringing blood to the patient, bypassing the liver through the ductus venosus into the heart, getting streamed right across the atria into the left ventricle, and the oxygenated blood coming out the aortic arch to reach the head and the coronary arteries. The venous blood from the supravena cava traversing the right ventricle, right side of the heart, out the pulmonary artery, and down to the lower extremities via the ductus arteriosus. So with the combined ventricular output of about 500 cc's per kilo per minute, we see the relative distribution of blood from the placenta, which has a low systemic vascular resistance, not through to the lungs because of its high pulmonary vascular resistance, hence the percent of cardiac output is very small. The highest saturation being preserved for the brain and for the coronary arteries. The lowest saturation coming out the ductus arteriosus to the lower extremities. We can pause at this point and ask the following question. The fetal circulation is characterized by all of the following except A, right to left shunting through the foramen ovale and ductus arteriosus. B, left to right shunting through the foramen ovale and ductus arteriosus. C, high pulmonary vascular resistance. D, low systemic vascular resistance. And E, the cardiac output is best characterized as combined output since it is derived from both ventricles simultaneously. Which of the following is incorrect? And the answer is left to right shunting through the foramen ovale and ductus arteriosus. Once the baby is born, these three shunts gradually close, except in some circumstances, and that is a condition known as persistent fetal circulation. And it results in persistent pulmonary hypertension of the newborn. So we have a transition period from fetal to newborn circulation where a number of changes occur. The shunts that were present helping to direct the blood flow become closed over a period of time. The pulmonary vascular resistance, which has prevented blood from perfusing the lungs, suddenly drops tremendously, marked decrease, allowing blood to perfuse the lungs. And the circulation becomes serial, that is, blood flows from the right side of the heart to the lungs, to the left side of the heart and the body, rather than in parallel. And then we see the change from normal circulation or a persistent fetal circulation, which is more pathological. At birth, the heart is immature. And it's immature for a number of reasons, all of which are shown here on the slide, both in architecture, metabolism, and function. And you can review these at your leisure, but suffice it to say, over a period of time, both the size and the functionality of the left and right ventricles change until the left ventricle becomes a dominant ventricle and the right ventricle becomes somewhat less important in terms of overall function. I mentioned that one of the most important changes that occur as the transition from fetal to postnatal birth is a change in pulmonary blood flow. And this arises as a direct result of a sudden decrease in pulmonary vascular resistance shown here at birth. The resistance decreases by about 200%, and the complementary increase in pulmonary blood flow that ensues ensures adequate circulation as the child begins to take the first few breaths. But the baby remains vulnerable to reversion of that pulmonary vascular resistance to very high values. And under what situations? Well, we see here on the x-axis, hypoxia causing an enormous exponential increase in pulmonary vascular resistance. Secondly, acidosis. As the pH decreases from 7.4 to 7.1, there is a 250 to 300% increase in pulmonary vascular resistance. So hypoxia and acidosis occurring for whatever reasons, be it infection, congenital anomalies, may lead to a sudden increase in pulmonary vascular resistance, which causes blood flow to revert to the fetal circulations type. And so persistent pulmonary hypertension of the newborn may be the primary effect, where the shunts aren't closing, or secondary to an insult. And they include meconium aspiration, sepsis, polycythemia, and congenital diaphragmatic hernia. We don't really understand the mechanism responsible for the decrease in pulmonary vascular resistance, but we do know that the pulmonary vasculature does dilate at birth as a result of a number of factors and interactions, not the least of which is nitric oxide, which is a selective pulmonary vasodilator. When administered in parts per million concentrations as an inhaled agent, is non-toxic, but there are a number of children who do not respond to nitric oxide with persistent fetal circulation, and we don't know why that is the case. The mechanisms we said in terms of regulating the pulmonary vascular resistance are varied, and the three main factors that are interacting to reduce the pulmonary artery pressures are nitric oxide, prostaglandins, and endothelin, all interacting through secondary messengers to lead to a reduction in pulmonary vascular resistance. Now, nitric oxide is important in that it facilitates this reduction in pulmonary vascular resistance, but in the presence of an oxidative stress where we have reactive oxygen species that are produced, we can override this effect, and despite all pulmonary vasodilators that may have been released, have a persistent fetal circulation situation that is unresponsive to nitric oxide. There are a number of situations where pulmonary hypertension is diagnosed, dependent in part on the position of the child, what drugs have been administered, and the type of ventilation that's being used. But when we find or suspect pulmonary hypertension, it's very important to assess the function of the myocardium and make sure we aren't dealing with a right ventricle that is unable to pump, to implement strategies known to reduce the pulmonary vascular resistance, including oxygen and hyperventilation, to ensure that the child remains warm because cold temperatures may precipitate this, exacerbate this problem, and have nitric oxide available. Again, recognizing there are some children in whom nitric oxide is ineffective. Sildenafil or Viagra has been used to try and reduce pulmonary vascular resistance in children who are unresponsive to the other measures listed above. Pain control, sedation, and possibly inhaled agents have all been used to bring down pulmonary vascular hypertension when it occurs in the postnatal period with varying degrees of success. So that brings to conclusion our review of this section, and we'll take a pause for a moment before we continue on with the next lecture.